Hello, everyone. Our group consists of Joan, Kalia, Nia, Janelle, and Zaina. Our presentation will discuss flaccid dysarthria. Our presentation will discuss the following content: pathophysiology of injury, case history, diagnostic procedures, diagnostic results, treatment plans, and SMART goals for treatment. Flaccid dysarthria is caused by impairments of the lower motor neurons in the cranial or spinal nerves. The origin of the lower motor neurons include the bulbar or lower pontine regions. This will affect the individual's speech or respiratory musculature. Pertaining to the hierarchy of the motor system, flaccid dysarthria is impaired at the level of execution, impacting communication of the muscles. Motor units associated with the types of flaccidity are characterized by weakness, including paralysis or paresis, hypotonicity, atrophy, hypoactive reflexes, fasciculations, fibrillations, rapid weakening, and recovery with rest. For individuals with flaccid dysarthria, usual presentations include slow and labored articulation, hypernasal resonance, and hoarse, breathy phonation. Flaccid dysarthria makes up 8.4% of all dysarthrias and 7.8% of motor speech disorders. The pathophysiology of injury for flaccid dysarthria are the origins of the lower motor neurons, including the bulbar or lower pontine regions in the brain and spinal nerve cell bodies responsible for controlling voluntary movement and reflexes. A common etiology of flaccid dysarthria is amyotrophic lateral sclerosis. ALS is a progressive lower motor neuron disease causing the degeneration of neurons that control voluntary muscle movement. ALS begins as flaccid dysarthria, then progresses to mixed dysarthria of flaccidity and spasticity. The case history is of our patient, Joe, who is a 65-year-old male with an early-stage diagnosis of ALS. Joe presents with muscle weakness, characterized by decreased strength, balance, and decreased functional independence. Joe was consulted to speech therapy for a full evaluation due to complaints of slurred speech, shortness of breath, tongue weakness, and frequent choking episodes. Pertaining to participation in life factors, Joe worked as a principal and recently retired due to progressive weakness of ALS symptoms. Joe is married with 4 grown children and 3 grandchildren. He enjoys spending time with his family, speaking at educational conferences, and volunteering at local schools to mentor new teachers. Since Joe continues to attend school events, family functions, and is an active member in the community, he expresses a strong desire to maintain the ability to communicate with his community, friends, and family. His wife and children are aware of his progressive disease and are very supportive of the treatment process.
Here is an overview of the diagnostic procedures that were carried out. We started with the case history, which was just discussed, and added a questionnaire to address life participation factors according to the International Classification of Functioning, Disability, and Health, or ICF. Then we conducted a cranial nerve exam to aid both diagnosis and treatment planning. A perceptual assessment of speech characteristics was performed, and finally, a measure of intelligibility was taken to aid in the planning of intervention.
Continuing more in depth with Joe's case history, we administered the Communicative Effectiveness Survey, which is a questionnaire focusing on the communicative effectiveness on a 4-point Likert scale. Scores of 2 revealed that Joe has trouble effectively communicating with family members at home. Scores of 1 also indicated that Joe has difficulty conversing with familiar people as well as strangers over the telephone. Joe also scored a 2, which indicates difficulty speaking with friends when he's emotionally upset. So Joe's quality of life is characterized by trouble speaking to others, difficulty socializing with friends, feeling upset or embarrassed, and frequently needing help from family for daily tasks or communicating needs. Next, during the cranial nerve exam, we noted that the olfactory and optic nerves were unaffected. When testing for the oculomotor nerve and trochlear nerve, we noted some weakness in eye movement. In terms of the abducens nerve, there was slight impact in lateral eye movements. When testing for the trigeminal nerve, we noticed difficulty with clenching due to weakness in the muscles controlled by this nerve. In terms of the facial nerve, we noted facial weakness such as difficulty smiling, frowning, or closing the eyes tightly. This is typical for patients in the early stage of ALS, contributing to flaccid dysarthria. The vestibulocochlear nerve seemed unaffected. When examining the glossopharyngeal nerve, We noted an absent gag reflex with difficulty swallowing as there is inadequate closure of the soft palate. This could be due to early involvement of the lower motor neurons. For the vagus nerve, we noted hoarseness and slurred speech. There was also some shakiness in the speech and reduced phonation. We noticed some swallowing difficulties. Again, as mentioned in the glossopharyngeal nerve, palatal weakness can be the cause of these deficits as it can manifest as nasal regurgitation fluids or difficulty in swallowing due to inadequate closure of the soft palate in addition to weakness of muscles that are innervated by this nerve. There was difficulty moving the tongue in various directions, so there was little control of the tongue. And there was also some tongue twitching, so tongue fasciculations when checking the oral cavity. And when he was speaking, we noticed some chin twitches. Joe mentioned that he had trouble chewing and swallowing the food, which is all attributed to these factors. There were no deficits when examining the accessory nerve, and overall reflexes seemed slower.
Next, a perceptual analysis of speech production was conducted. Results indicated imprecise and slow alternating motion rates, AMRs, and a slowed speech rate. Difficulty was especially noted during the production of P due to weak lip closure and likely related to facial nerve damage, and the production of K likely related to weak elevation of the back of the tongue from hypoglossal nerve damage. When testing prolonged vowels, reduced maximum phonation time was noted due to weak breath support. Voice quality was breathy and hoarse, with nasal emissions detected. These issues are likely caused by ineffective closing of the vocal folds from vagus nerve damage. To assess contextual speech, the patient was asked to read the grandfather passage, and conversational ability was observed during the initial interview. Prior cognitive and reading difficulties were ruled out based on the case history. During conversational speech, monopitch and monoloudness were noted, implying weak laryngeal muscles due to vagus nerve damage. Other characteristics were detected which also implicated vagus nerve involvement, such as audible inspiration due to issues with vocal fold abduction, hypernasality due to velopharyngeal valve weakness, and short phrases due to wastage of air. The patient also exhibited significant imprecise articulation, including the lingual and plosive consonants. Lingual consonants are likely impacted by the hypoglossal nerve, while plosives are likely impacted by facial nerve damage, causing weak lip closure, which was also confirmed during AMR testing. Stress testing was also conducted, with results indicating minimal deterioration of speech, ruling out myasthenia gravis involvement. Finally, intelligibility was assessed using the intelligibility subtest of the French Dysarthria Assessment 2nd edition, FDA2. Out of a 5-point scale with a score of 1, meaning completely unintelligible speech, the patient scored a 2, mainly due to imprecise consonant production and slowed rate of speech. Multiple cranial nerve lesions are likely impacting the patient's intelligibility. Analysis of the evidence collected points towards a diagnosis of flaccid dysarthria. Darley, Aronson, and Brown note the most prominent features of flaccid dysarthria include hypernasality, imprecise consonants, breathy voice, and monopitch, all of which are evident in Joe's speech. Significant weakness was also noted, another hallmark of flaccid dysarthria.
In developing Joe's treatment plan, goals were collaboratively identified by Joe, the clinicians, and his family to facilitate participation in meaningful activities and roles. Recognizing the irreversible nature of ALS and its impact on Joe's quality of life, our approach aims to optimize Joe's potential to participate in meaningful activities. Our plan focuses on addressing key areas to enhance his quality of life and maximize his communication. These encompass self-advocacy, dysphagia, respiration, articulation, resonance, and the use of augmentative and alternative communication devices. With Joe's recent ALS diagnosis, we want to ensure that Joe becomes an active participant in his own treatment. It is essential to support Joe in advocating for his needs, preferences, and goals, and with that, tailoring his own therapy sessions based on his unique communication challenges and clinical manifestations. Based on Joe's aspirations and our clinical expertise, we've identified key treatment priorities. This includes self-advocacy, or training Joe to advocate for himself by employing speaker strategies to enhance comprehensibility and prevent communication breakdown. These strategies hold particular significance for individuals who use augmentative means of communication. Two example self-advocacy goals include Joe will present his self-advocacy script when appropriate during conversation with unfamiliar listeners in 90% of opportunities, and Joe will disclose that he is a person with ALS and flaccid dysarthria to unfamiliar communication partners in 75% of opportunities. A high priority clinical manifestation that Joe, his family, and our team of clinicians have decided to address comes from the disclosure that he has frequent choking episodes. As well, during our cranial nerve exam, we observed this weakened gag reflex due to the inadequate closure of his soft palate. To treat these aspirations and overall weakness, we find it imperative to teach Joe postural techniques and swallow maneuvers. We have decided to use an effortful swallow against resistance treatment that combines the effortful swallow maneuver and the chin tuck postural technique. The simultaneous nature of these exercises has shown to increase time efficiency and intensity of both exercises by pushing the muscles to do more as a combined exercise than doing each of them separately. During sessions with Joe, our procedures would consist of having him press his chin down into the chin tuck position and holding for 30 seconds. While holding this position, we would ask Joe to squeeze hard with all of his muscles and swallow hard. Return to the starting position and repeat this exercise 10 to 20 times per session. The maneuver and the technique allow for improved tongue-based retraction and widen the follicular space when swallowing. We aim to reduce the risk of aspiration and encourage safe eating habits to prevent the risk of serious health issues for Joe. An example dysphagia goal we have created is Joe will utilize and hold the effortful swallow against resistance for 30 seconds to eliminate signs and symptoms of aspiration during 3 out of 5 swallow opportunities given moderate visual and verbal cues.
Expiratory muscle strength training, or EMST, is commonly used for flaccid dysarthria to strengthen weakened respiratory muscles in order to improve breathing and swallowing capabilities. The user must blow into a handheld pressure threshold device with sufficient force to overcome a physiologically challenging preset resistance. The resistance is set at a level below maximum expiratory pressure. The exercise regimen involves repetitions of blowing into the device with sufficient force to overcome the preset threshold, with the threshold adjusted upwards as the program proceeds. Aims of this treatment include increased loudness, number of syllables per breath group, speaking endurance, and inspiratory speed. Evidence supports that EMST can improve respiratory strength and swallowing function in individuals with dysarthria, neurologic disease, respiratory weakness, and dysphagia. Our goal for this treatment is that Joe will complete 60 trials of EMST on his handheld pressure threshold device within 20 minutes.
Results of the intelligibility scale reveal that Joe presents with moderate to severe intelligibility characterized by imprecise consonants. Functionally, as Joe and his family's concerns involve his slurred speech, Joe would like to improve his intelligibility to effectively communicate with unfamiliar listeners when engaging with the community. Assessments conducted by clinicians revealed slow speech and difficulties producing p and k precisely after analyzing his alternating and sequential motion rates. We know that this is due to his weak labial movements caused by facial nerve damage. To target these characteristics, we plan to use an over-articulation program that utilizes drilling with him. This program will focus on teaching Joe to exaggerate the movement of his articulators to improve articulatory precision and encourage slow rate of speech. This will involve collecting words that are salient to Joe and difficult for him to produce. Then we will teach him how to exaggerate the consonants by using larger movements of his lips, cheeks, and tongue during production of those words to improve his precision and accuracy. An example goal to target articulation for Joe is Joe will over-articulate consonant sounds in the initial and final position of 15 monosyllabic words in 12 out of 15 trials given moderate verbal support.
Velopharyngeal insufficiency often leads to resonance issues in individuals with flaccid dysarthria. Continuous positive airway pressure is an evidence-based velopharyngeal strengthening exercise that is specifically effective for treating flaccid dysarthria compared to other dysarthria types. It is a safe, non-invasive, and relatively conservative treatment method for reducing hypernasality in dysarthric speakers with velopharyngeal inadequacy and weakness. CPAP delivers positive airflow into the nasal cavities through a hose and nasal mask assembly. The velopharyngeal muscles are challenged during speech to overcome this positive airway pressure to achieve velopharyngeal closure. By using this machine during speech exercises, the pressure creates a resistance that the velum must contract more forcefully to overcome, thus strengthening its muscles. Using the CPAP machine during speech exercises helps eliminate the need to transfer this increase in velar strength and movement to conversational speech. CPAP has been proven to reduce hypernasality through strength training of the velopharyngeal muscles that helps modify the degree and timing of velopharyngeal closure. While undergoing CPAP treatment, Joe will produce 50 VNCN or vowel nasal consonant pressure consonant vowel nonsense combinations with stress on the second syllable within 20 minutes. AAC serves as an option to augment or substitute other means of communication for speech and includes low technology, non-electronic materials such as word boards or more high-tech, sophisticated electronic devices. It can be especially beneficial for people with degenerative diseases like ALS. In Joe's case, and given the progressive nature of ALS, it has been determined that AAC could potentially greatly improve his quality of life, so a combination of speech and AAC strategies will be used. Our treatment will focus on efforts to maintain speech, develop compensatory strategies to maintain intelligibility, and address current or future needs for AAC to maximize communication, not reverse decline. Joe's intelligibility has been impacted, so we would want to explore different AAC modalities early in his treatment plan. After Joe has chosen a device that best suits his needs, we would work on instruction and practice with the device before introducing the message banking function to him, where he will be able to input salient phrases and words to use in meaningful settings as he deems necessary. Our goal with AAC is that, in collaboration with the clinician and immediate family members, Joe will add 10 meaningful phrases across 2 sessions to his aided AAC speech-generating device message bank to convey wants and needs in specific situations. Other notable treatments for flaccid dysarthria are listed below, which are designed to increase strength or compensate for weakness. For respiration, it is essential to increase the physiologic support for speech breathing. Pushing-pulling exercises can be used to increase respiratory support and drive. Postural adjustments, prosthetic aids, and compensatory efforts like deep inhalation are more commonly used techniques for treating flaccid dysarthria. For phonation, surgery or injectable substances to bulk up the vocal folds are also more appropriate. Effort closure exercises can help with vocal fold weakness or paralysis. Resonance and velopharyngeal function is focused on in flaccid dysarthria more frequently than in any other type. Patients with flaccid dysarthria are often candidates for palatal lift prosthesis and pharyngeal flap surgery. Postural adjustments or nares occlusion can help prevent excessive nasal flow during speech. For prosody, pitch range exercises, contrastive stress drills, and chunking utterances into syntactic units may be used to support the naturalness and intelligibility of speech. And for articulation, intelligibility drills, phonetic placement instruction, and minimal contrast drills can help with loudness, imprecise consonants, and slurred speech. Working on loudness is beneficial as it may induce changes in articulation. To reiterate, Joe has ALS resulting in flaccid dysarthria secondary to cranial nerve involvement. A treatment plan was developed with his communication needs and pathophysiology in mind. The needs and abilities of all patients with this disorder can vary greatly since it depends on which cranial nerve or combination of nerves are damaged.
And that concludes our case review of flaccid dysarthria. Thanks for listening.